Hello, everyone. Thank you for joining this practical session about the GDT guided holoclast therapy. Before starting, so quick introduction about the GDT. So for those who did not attend the last session about the GDT, so what is GDT? It's a new concept which has been launched by the end of last year by the company EMS, Electromedical Systems, and it's a concept combining therapies around extracorporeal shockwave therapy, high power laser, physical and rehabilitation exercising. And we are excited today to do this practical session with Daniel Morgan, our GDT specialist. Thank you, Daniel, for being with us today. We have also a nice model with us, Chris, who will serve as a nice patient. So just a few technical points. If you have any questions, please use the chat section at the top or the bottom of your screen. You can also use the Q&A section to answer your to put your questions in there. So my name is Mary Christine Collette. I'm an education specialist for working for EMS, and we are promoting all these GDT and SDCA shockwave and laser trainings worldwide, offering all these trainings to practitioners who would like to go further into this concept. So that's it for the introduction. So Daniel, off you go.
Well, let me just share the screen, and then there you go. I think that will do it. How do I play? There you go, play. Right. Okay, so as MC said, my name is Daniel Morgan. I've been training and working alongside the EMS now for a number of years, and obviously trying to now kind of go through as well with the new concepts that we're developing and working on, which is the GDT, which I was fortunate to be involved with throughout its kind of its birth and infancy, I guess. So let's see if we can change. There we go, slide. So before we begin, obviously, a little bit about the Swiss Holoclast Academy. We've got over 200 Swiss Holoclast Academy courses a year, with 70 official trainers from 24 different countries, and that has led to over 5,000 certified practitioners in more than 30 countries. Obviously, what we're trying to do is we're trying to spread knowledge of the Swiss Holoclast Academy or the Swiss Holoclast methods, and now that comes into the GDT concepts as well. What you get from joining the Swiss Holoclast Academy? You can get your practice listed online, and obviously if your patients are looking for somebody in your area that are looking for somebody who carries out shockwave therapy, then you can get listed. But it increases your exposure, it can drive your business a little bit, and obviously you get added to this online directory. Certainly in the UK as well, we do have kind of a shockwave Facebook page which you can get added to, and those sort of things where you can ask some questions, and I suppose that can be certainly widened towards laser questions as well. So obviously the expertise was based on clinical evidence. It's customized training programs, and it's all based around the latest scientific advances and research. From an excellent standpoint, it's streamlined training model, and we look at the clinical efficiency and safety of the GDT. It plays a key role in professional sports. I've used it when I've been working in elite sports this year, particularly. And it really does have a strong impact on patient satisfaction. I was using the laser in isolation this morning, And obviously what we'll look at predominantly today is going to be the combined concept of using laser and shockwave in a single session to enhance outcomes. And from an exchange perspective, this is what we're talking about from the academy and what this gets you. You get an international network of instructors that you can email and kind of reach out to. You get school presence and partnerships, exchange of expertise, and again, this will be nice on online forums. And obviously, we get to inspire future generations to try and get involved with this approach and try to get people moving better, more freely, and with less pain or pain-free. So, very quickly, for those of you that don't know about the GDT, it's a 6-step approach and with one goal, which is essentially pain-free patients. In the first phase, we want to assess and engage with those patients. So we need to establish a diagnosis, and that's one of the ways that we will do that from this first assessment. This will be including orthopedic examination, questionnaires, those type of things. The second phase then is going to be this dollar class high power laser, which you can see just right behind me there. And the dollar class high power laser is the second phase and is the first phase. It's sort of hands-on phase from this concept and from the therapy itself. We then add in phase 3, which is going to be radial shockwave or focus shockwave. So 3 and 4 are the second stages to your intervention process. And then we move on to rehabilitation and then follow-up assessments, which again will be pretty much looking at your previous assessments and seeing if there's a change and how has that changed. But it's a new concept that is able to essentially treat 90% of patients suffering from musculoskeletal disorders. And basically it gets unrivaled performance and outcomes. I think that when we start using these things in combination, we're already getting good results with shockwave, and adding this additional high-powered laser really does seem to get better outcomes, certainly anecdotally, and research is pending on that at the moment, which is really quite exciting. But it really can be a game changer, for the tendinopathy stuff that we all know and love and treat and are very good at treating, but also for your subacute and now acute conditions that we can also really benefit from adding the high-powered laser in as well. So just a quick example of a few of the conditions that we can treat is tennis elbow, rotator cuff tendinopathy, upper back pain, adhesive capsulitis, lower back pain, golfer's elbow, patellar tip syndrome, knee osteoarthritis, plantar fasciopathy, and Achilles tendinopathy. And the patient that I treated this morning was actually an Achilles tendinopathy patient. So, we're using it daily in clinical practice, and that you do get very, very good outcomes with it. So the clinical effects, obviously we're looking at pain relief, and the laser has an impact on pain relief, as does the shockwave. So at the site of injury, the laser inhibits the nociceptors, which are responsible for the transmission of pain to the brain. And obviously with the shockwave, we know that we activate the C nerve fibers, essentially reducing substance P as well, and all of that kind of stuff, which is a neurogenic inflammatory response as well as the localized inflammatory responses there. We get a reduction of inflammation, so decrease the amount of prostaglandins E and fatty acid, which is a fatty acid responsible for mediating the acute inflammation, thus reducing redness and swelling of tissues. We also reduce the release of injured tissues and spinal cord of substance P, which is again responsible for mediating that neurogenic inflammatory response. So the shockwave has this neurogenic inflammatory response, and the laser has a more localized response within that tissue. Obviously, tendon repair, tendon remodeling, the rest of that then is really where the shockwave comes into its own. But I want to really focus on the new addition to all of this, which is going to be the high-powered laser. So here's just a quick list of the literature that we have essentially got all of this information from. So it is very evidence-based. We have Biodal et al., which is the new kind of research that we've looked at from the laser, Mizawa et al. As well. That was a kind of a nociceptive literature review that was carried out in, I think it was early studies, those, but still that's where the basis of the fundamentals come from. So just a quick run through of what indications are covered by high-powered laser. So we have your rotator cuff tendinopathies, your trochanteric bursitis, your glenohumeral arthritis, hamstring enthesopathies, acromioclavicular arthritis, adductor strains, proximal bicep tendinopathy, facet arthropathies, and the list goes on. There's an abundance of kind of treatments and pathologies that we're able to treat when it comes to the high-powered laser. We can add all of that in, and when we cross that over then with indications that are covered by shockwave, you've got your tendinopathies again, your adhesive capsulitis, your trigger points, myofascial pain syndromes, and so all of these aren't new to us. We know that we use this in clinical practice already with shockwave. And then the Piezoklast, which I have spelled wrong, but there's a little typo in there. The Piezoklast is obviously going to be your more focused. Sorry, let me go back. There we go. Your focused device. I won't be showing you the focused avenue. It will be radial shockwaves today, as we have the new radial shockwave device behind me. But this is kind of for your very stubborn, really difficult tendinopathies and calcific tendinopathies or calcifying tendinitis. Really like stubborn tendinopathies is where we kind of look to use the Piezoklast and it's the more focused devices. So yes, okay, we can use these as standalone treatments. So high-powered laser is for superficial or deep indications. So I'll come on to that in the science, but we can actually get a great deal of penetration with the laser because of the specifications that it holds. It's ideal for the acute phase of care. So acute tendinitis or acute inflammatory process, then absolutely superb for that. And it should be your first choice to address important pain and acute inflammation in any musculoskeletal disorder. So that's the high-powered laser. From the radial shockwaves, obviously, for more superficial indications, so superficial tendons, it should be used in subacute or chronic pathologies. And really, it's your first choice. It is your first choice. It does get you your better outcomes compared to conservative management alone or compared to rehab alone. From all the literature that we've looked at over the years, we know that combining shockwave with rehab, it gets you better outcomes than just doing shockwave alone, and it gives you better outcomes than just doing rehab alone. Your focused shockwave then is obviously your Piezoklast, and that is for your deeper tendons. You get greater penetration, greater energy from your focused device, again in those subacute or chronic phases, and it's your first choice really for those deep calcified lesions. And the really stubborn tendons, tendinopathies is also where this comes in. So if you failed your response to care with radial, then you can certainly add in your focus then. So here is your high-powered laser, and it's highly powerful and it tackles musculoskeletal pain within 5 minutes during that acute inflammatory phase. The patient that we had in this morning had a little bit of an aggravation following an Achilles tendinopathy, just to increase their load too quickly. We put the laser on, 5 minutes, absolutely reduced down that pain sensation within that 5-minute protocol, leaves pain-free. We can now get him loading appropriately again. So it's really suitable for those patients who are suffering from the acute phase of pathology. And then obviously in combination, we can use it in those subacute and chronic phases as well. It really is good, certainly from the arm perspective as well, which is nice. So you can actually just leave that on the patient and you can do whatever you need to do. There's certainly some clinics around Bristol in the UK that do that. I tend to be more kind of in the room with the patient during the entire treatment. So I'm happy to do it as a manual therapy as well as, but it does offer that automatic arm which you can leave on to the patient, which is really nice and great for you as a practitioner. Saves you a bit of a job. So here is obviously your radial shockwaves, and it
Daniel?
is hello.
Sorry,
yeah.
sorry to interrupt. We already have two questions concerning the slides you were talking about just before. We have the first question is: are there any devices which can treat the acute phase? And could you please advise the time frame of acute and subacute phases?
Yeah, that'll come up in a bit. That's on one of the slides in a minute. So yeah, no problem. We've got that in terms of a pathway choice for that in a bit. So there's no problems with that. But yeah, the high-powered laser is there for your acute phases. So that's where we would typically use that in isolation. From a time frame perspective, we start to look at it step 1, step 2 combined. But realistically, what we're thinking is that in the first kind of 6 weeks that's your acute phase. Then 6 weeks to 3 months is kind of your subacute, and then it becomes your chronic phases thereafter. But yeah, absolutely. You can definitely use your laser in those acute phases in those first couple of weeks, where it can come in quite handy, just to reduce down those pains. The time frames are variable depending on who you listen to. But realistically, in the first couple of weeks, in the first month, that's when we wouldn't really look to start using shockwave. We would use your high-powered laser in isolation. From that point on, then you can start to use it in combination. So yeah, first couple of weeks, first 4 to 6 weeks is your high-powered laser in isolation, I would say. Then you've got your radial shockwaves. So obviously it's unrivaled performance, ensuring the best clinical outcomes, and it is now in a lovely portable device, which means it can be shipped. It can be lifted off the stand nice and easily. So we haven't compromised any performance levels with that from the old Master Touch, and it is able to provide it's a miracle really that it's able to provide the same level of performance in a smaller unit with 2 internal compressors. So yeah, really, really good. We haven't compromised anything from that perspective. We've actually also redesigned a new handpiece just to increase the clinical efficiency. So yeah, it's superb. So we can't really fault the radial device, the new radial device, and you will see that in action again in a little bit. And obviously your Pisa class, I don't really want to spend a great deal of time in the Pisa class because we're not going to run through it a little bit today. But again, it is going to be for those really calcitrant tendinopathies, those really stubborn tendinopathies that just will not respond to a great deal of anything else. So this is the kind of the summary of it really. We have the Doll class high power laser as your first step. And what that is just a 3-minute protocol. It's a set protocol that is on the machine. We just use for 3 minutes. We have a 905 nanometer wavelength, which inhibits the pain. And obviously that wavelength is also the same one that is able to decrease the amount of prostaglandins within the tissue. So the same wavelength that is for use for nociceptive aspects of it is also used then for your prostaglandins and your anti-inflammatory aspects of it. We have a strong analgesic effect kicking in we're probably within 5 minutes after the end of that session, and then the anti-inflammatory effect really kicks in at kind of around about an hour. So immediately the patients will be like, oh, that feels easier, and then within that hour the actual anti-inflammatory effect kicks in as well. So the research is suggesting it's as good as NSAIDs without any risks. So without the risks of abdominal bleeding, without the risk of ulcerations. So without those sort of risks, we can get as good a result from a pain relief and from an anti-inflammatory perspective. We then wait either 5 minutes or an hour. Today we will be doing the clinical approach that I use, which is just going to be 5 minutes. And then we go on to our shockwaves, which is going to be your standard shockwave protocols. And we all know what shockwave does because we've kind of probably all been using it for a long period of time now. So just a really quick run through on the fundamentals of the laser. And what we know is the therapeutic window for laser is between 650 kind of nanometers and 1350 nanometers for the wavelengths, and we fall right in the middle of there. Really, we're at 905. So that 905 has been chosen for a number of reasons. It's been the optimum for nociceptive, it's optimum for anti-inflammatories, but also it's the optimum wavelength that has been shown for absorption. So there's less absorption by water, there's less absorption by blood and melanin, so it can reach deeper tissues without really having any thermal effect on the tissue that it's obviously passing through. We also have a pulsed laser, and that again is there to reduce the heat. We have a number of settings there that's going to be your peak power, which is up to 300 watts, and that is up to kind of 15 times more powerful than any other laser that's on the market at the moment. Pulse durations, so that is the amount of period of time that laser is on, and then the frequency is obviously the amount of kind of kilohertz per, the amount that is pulsed per second, and then you have the modulation, which again is the percentage of time that is on. So it's a pulsed laser, which is how we're able to get away with those high energies, and that's why it really doesn't absorb a great deal of thermal effect onto the tissue. It can be a little bit different if you have darker skin, and it can be a bit different if you're going over tattooed areas. So we advise you to use a hypersensitive setting on those patients. But it is a little bit uncomfortable for those patients. It can get a little bit burny, but that's why we adapt the settings to suit. As I said, the 905 nanometers, why? We've shown, though, there has been research to show that based on the period of time, 3 minutes is a big question, is why do we choose 3 minutes? 3 minutes has been proven to be basically the optimum. Anything over 5 minutes, or anything from 5 to 10 minutes, you get the same effect. 3 to 5 minutes is very similar. So we can get just as good outcomes with 3 minutes as we can 5 minutes. So why spend 2 minutes extra on a patient that you don't necessarily need to spend? So you can definitely do that within 3 minutes, and that again is the 905 wavelength. And obviously, as we said, the suppression of acute inflammation with the effect on the prostaglandins there, that's that real acute anti-inflammatory effect that we see within this wavelength. So ultimately, we have high power, which means better penetration. We have the specific wavelength, which is better for absorption or lack of absorption, and it's also better for your anti-inflammatory and nociceptive avenues. So the specificity and the specifications of this device is what basically leads to its excellence and gets the best clinical outcomes. And that is again just showing the peak power at 300 watts compared to competitors, which is at 20 watts, and it's obviously significantly more powerful. We can get up to 8 centimeters of depth of penetration with this. So those deeper, really deep tendons, that we can reach that still. So there's no issues there. It's actually 12 centimeters, sorry, of penetration with it. So you've got no issues there with reaching those deep tissues, those really deep hip tendons, or even if you've got a larger patient with a low back, you can definitely have an effect with those patients, getting into the facet joints, getting into the surrounding musculature around it as well. So yeah, no problem with those. Then just to summarize, this is kind of what we will be doing. So you've got your high-powered laser initially, 3 minutes of that, and then we wait 5 minutes and we progress then onto our standard shockwave approach. Today, that's going to be the dollar class radial shockwaves, and we will work through those. So I'm ready now for the practical session. Sorry to keep you, but we'll go on with that, and we'll do the shoulder if everyone's happy to do the shoulder, and show you how I typically do that in clinical practice. So, Chris, are you all right to nip your top off me? Okay. Let me wheel this out of the way. Yeah, go on. I'll unplug that. Right, we'll do this. This is the bad one? Yeah, that's the bad one. I knew that. Let me put my apron on. while we go in there, MC, is there any questions?
We have comments. From and questions from Robert about the laser. I guess he works with a K laser and was asking, how does the EMS high power laser compare to others on the market? In particular, what is your response to those who say you are only offering one wavelength, 905 nanometers, where others are offering up to 4 wavelengths, and who state that 905 nanometers primary action is on oxygen dumping, where 800 nanometers works on stimulating enzymes such as cytochrome oxidase C?
Yeah, so we've obviously chosen the 905 because of the absorption rates, so you get deeper penetration, as we said, and we've also get the prostaglandin and the anti-inflammatory effects. So I think a lot of the multiple, like other lasers, will use multiple wavelengths to affect different things like fungal treatments, etc. We want to purely be focused on MSK because that's where we've always kind of had our kind of basis, I guess. Our basis of treatment has been surrounding MSK. So realistically, we found that the 905 wavelength is the best for the anti-inflammatory effect and the nociceptive effects. So what I'm pretty happy with is that obviously it works on those musculoskeletal conditions specifically. I think that it's one of those ones where if we start delving into other avenues and trying to treat other issues with other specific wavelengths, kind of dilute your expertise a little bit. And I think that what we've kind of done is just focused on musculoskeletal conditions because that's where we set our basis. You know, this is the best outcome or the best settings for musculoskeletal conditions. So I'm quite happy with that. I don't think that we need to be changing the settings or the wavelengths because that it's optimum for the conditions that we want to treat. Does that make sense?
It makes sense, definitely. And he was asking another question. Is it delivering the required power, energy, and depth in keeping with the literature, in particular with subacute and chronic pathologies?
Oh, I don't understand that question. Sorry, MC. Yeah.
No, sorry. Sorry, you cannot be everywhere, obviously. Robert was asking another question, is it delivering the required power, energy, and depth in keeping with the literature, in particular with subacute and chronic pathologies?
Yes, yeah.
I guess so.
100%. Right, so we will, Chris, I need to get your glasses on, and then we'll get going. So that's for you.
So, Robert, if you don't work for the moment with any laser, you can give it a try with a high power laser dollar class.
All right, here we go. So I can't see the screen very much now, right? So I'm just gonna go with wherever. I can obviously see Chris, but the screen is quite dark, so I'm just gonna, if there's any issues that you can't see, just let us know.
That's fine, Daniel.
So Chris, what we're gonna do, we're gonna bring this around the back for me, right? So we're just gonna work, so typically we would look at like a calcific tendinopathy or a supraspin tendonitis or tendinopathy here. And when we bring Chris into this position, we know that the supraspin is then brought more to the forefront. So that makes it a little bit more accessible. I am fogging up everywhere with these now as well, because I'm breathing and masks and glasses are not ideal. Right, so we get ready to go. Safety glasses are on. The unit warns you that you should have your safety glasses on. And we start. So it's on. And Chris is obviously relatively comfortable with this. There's no, you don't feel anything. There's no pain. There's no real burning sensations. What I tend to do is I tend to just want to move the laser slightly around If you do leave it there for a period, it can get a little bit warm. So we just tend to move it around a little bit, just a couple of like a centimetre up and down. I cannot see a thing, nothing. There we go. So we've just got 3 minutes of this. The actual settings is the frequency is 60 kilohertz and the modulation is 70%. And that will then provide an energy of 243 joules to the tissue. So this is kind of where we're at with it, in the sense of these settings are what are best for the, again, anti-inflammatory and nociceptive responses. Certainly during this 3 minutes, so it's a really short time frame where we just apply 3 minutes of energy, really. I'll tell you what we should do, Chris. We should just quickly see how the movement is after this as well, because you were particularly struggling like out, weren't you? Chris is a patient here anyway, but Chris has particularly been struggling with kind of abduction in the recent weeks. Yesterday in the gym, yeah. So yesterday he went to lift lateral raises and was feeling a little bit of an impingement in there. We've been working quite a bit on functional stuff with Chris on his shoulder, and it just seems like he gets an irritation every month or so. Yeah, it's not like Chris is quite well, he's a high level, very high level, life-saving, well, athlete, I guess, yeah, and works at, like, has competed in European Championships and World Championships, so. So swimming, so it's not your strong point, swimming though, is it? But running is, sprinting is just a strong point. Right, so we have 15 seconds left on this, and no burning, nothing, Chris, nothing. Good. Right, good. 5, 4, 3. Done. Okay. So now we have you can relax that down. We got 5 minutes where I will set that on my timer. And we have 5 minutes of just ease. So during this time frame, you can do whatever you want with the patient. We can be doing some soft tissue work. You can do some manipulation if you're a chiropractor or osteopath, or otherwise. You can start to really work around it during this 5 minute time frame. But obviously, we'll allow this 5 minutes to pass, and then we'll crack on and we'll do some of the shockwave into the shoulder as well. Now, Chris, we'll do it after the 5 minutes, and we'll just see how his range of motion feels afterwards, because I might get a band, or I might do it resisted, so we can actually see whether or not you can load it a little bit freer. But yeah, so that's the basic principle of the laser here, is that I can take these off now. We just apply 3 minutes into the area that you find in the pain and the kind of the symptoms, and then we can progress then on with your really nice and what we know and love in the shockwave. The idea being, the initial sort of thought process is that we can apply more energy now into this tissue, because there's a nociceptive response, which means obviously it's not going to be as painful. We can actually put in more energy into that tissue, which will optimize the recovery. We know the more energy, the better, but obviously we don't want it to a point where it's so painful that they can't tolerate it. So at this point, we kind of expect what the kind of preliminary research is suggesting. We probably will be able to add around about 50% more energy into this, which is great. So if we can add a little bit more energy in, and that will get better outcomes for Chris, then that's exactly what we want. So we are 2 minutes into our 5 minute break. Is there any questions during that, MC?
Yes, we have questions.
Okay.
We have a question from Winston asking, would you need to adjust settings for males and females as thermal sensitivity is shown to differ between them?
No, we don't. The only time we really need to adjust the settings, is, like I said, is if there's anything for tattoos, or if there's anything with kind of darker skin tone. Predominantly reason there is that obviously the melanin levels will play an effect on the absorption, and then that will get a little bit of a thermal response. And when it comes to tattoos, the ink warms up and it becomes very burny. Yeah, it's a little bit uncomfortable for the patient when you go over tattoos. You have to, there is the settings on here ready for the hypersensitive patients, and you just change to that setting. So it just changes it a little bit, and you can then go over those tattooed areas. Or if obviously you're dealing with somebody with darker skin, then you just put that setting on first as last and run through it. So there's no change for male and female, just for kind of skin tone, pigment, and tattoos is where we change the settings really. Obviously you can, when you're doing it as a standalone session, you have specific settings on here. The first 5 minutes are pretty much always the same. That is your nociceptive response. The rest of it then will be tailored towards the condition or the action that we want. So for example, anti-edemic kind of indications will be different to your anti-inflammatory indications. The time frames are a little bit different. So if we go back and we go into actions, for example, and you want a soft tissue anti-edema approach, that will be 25 minutes worth of treatment there. And then if we go on to a analgesic approach, that is 3 minutes worth of treatment. So dependent on your goal and your outcome and your main kind of what you want to achieve from treatment, the settings automatically adapt for you, depending on the setting that you choose. But from a perspective of the GDT, 3 minutes prior to doing this in combination with obviously the shockwave, and then go from there.
Okay, perfect.
Does that make sense?
That makes sense. Thank you.
Good.
And with regards to tattoos, is it due to the presence of particles of metal that could be, present?
Yeah, potentially. Yeah, maybe. Yeah.
Depending on the quality of the tattoo, of the ink. I mean,
it depends. Yes, it's the ink. It is. It's the quality of the ink, and it depends where it's been done. Obviously, but yeah. It's the ink. The ink will obviously absorb heat. It happens. You've got one tattoo there, haven't you? So it happens. Like, did you find that with the sun, for example, it just the first time you had it felt really warm? So it's a similar sort of principle from, yeah. So it's a very sort of similar principle to that in the sense that it just absorbs more heat. It's like if you put, kind of like a bag out in the sun and they're of different colors, they'll absorb more heat because of the reflective properties of light. So it's exactly the same. It's just that this is fully absorption rather than any kind of reflective principles. But yeah. Right, we're over that kind of 6 minutes now, so actually we're over the 5 minutes. So just out of interest, Chris, which way are you particularly struggling laterally when you? So okay, Chris is actually, that doesn't give him any pain at the minute anyway, so that's really good. Just what if we press up against me and do it that way? Out to 10? Okay, so there's a little bit of pain there. So if we now add that into a shockwave, what do we do? Where should we go? Let's do 2000, 12 hertz. And we start relatively low and ramp it up. So I'm going to use a new feature which is on here. We're going to use the ramp up feature, which means it's going to start relatively low, but it'll automatically increase the setting, increase the bar. So we're going to go for just 2000 impulses, 12 hertz, and the start at 1.8, and then it will gradually increase as the time goes on. Bring that around back for me again. I have cleaned all of this, so this is all good. What we're going to do, I'm going to get, right, we'll drop it down. We'll start at 1.5 and we'll do a ramp up. So I've got a ramp up set in 2, which means that every certain number of impulses, I think it's every 300 impulses, the bar will go up by 0.1. So that's the setting that I'm going to use. This is my favorite that I use in clinic. You have other settings, which are going to be an analgesic approach. You have a burst approach as well. So you've got all of that. But I'm just going to go for a gentle ramp up. We're just going to do that, and then you guys see, I'm just going right on to the tendon attachment there. Very much the wrong side to it. Yeah, the left. Yeah. There. Okay, over 10. Okay. So we're on 2 bar at the moment, and this is Chris saying it's about 5 out of 10, 6 out of 10. So keep it at such a tolerance, which will probably be around about 2.5, I'd say. Hey, less than a minute. Oh, there we go. Oh, right, we're on 2.5. Where are you there? Over 10. Actually, down in terms of this tolerance now. So Chris has had that adaptive response. So a 2.6 out of 10, and he's not really uncomfortable at all. 2.8. Yeah, great. Yeah. Right, great. So we got up to 2.8 bar there, and Chris is relatively comfortable. So he actually got higher than I was expected, which is really good. Which again just emphasises the fact that we're able to put a little bit more energy into this tissue now after the laser, which is great. So let's have a little. I'm going to do one more through the actual super spin. So we're just going to put a quick burst there. 1,000, bring that down to 2. So what I tend to do with any kind of shoulder issues, I don't think that's the right one, might be. I tend to just run through the actual muscle belly as well and the muscle bulk. So with this one, because we know that Chris is struggling with abduction. The first 15 degrees is going to be the super spin. So we may as well try and work through that super spin and see whether or not that's going to change the strength and the capability of Chris's tolerance really against load. I'm still expecting this to be a little bit painful after after we treated it. I don't expect it to be kind of gone in terms of resistance, but I'd like to be able to get a little bit more resistance against that shoulder. I may be wrong and it may be completely gone, but we'll see. It'll be a bit of a test. Yeah. So we're okay to do this over the cubic fin, particularly angling down, because the scapula is there and shockwave can't penetrate through bone. Around the top, it's a little bit more cautious. Obviously, we have the line directly underneath. Right, cool. This is going to be the big test. Let's see how much Chris can withstand. Chris just said, no, we did this with Chris when he had a proximal hamstring injury. He just said that really didn't hurt as much as what it did with his leg. So that's a good sign. Okay, so let's have a little go. Let's try the movement first, and let's just. It's fine. Okay, go on. No, that's a different world. That's an absolutely different world. Okay, go again. Look at that. And I promise I haven't paid him to say that. That is a genuine, that's a genuine response, which I'm really pleased about. So what we would typically do now is, again, from my perspective, from a full treatment, I would look at the neck, I would look at the thoracics, and just try and use all of that while he's here. But that's it from a GDT perspective. So I'll show you potentially a hip while we're here, may as well. Or do you want to do back, seeing as you've got your top off? We'll do the back. So go face down for me, if you can. Head up that end. I'm going to raise this. Now, what I'm going to do, I'll raise the camera angle a bit.
Daniel, we have a question from Ingrid asking, what are the contraindications?
So the contraindications for the laser are pretty much anything over that, kind of metastatic growth and fibromatosis and things like that. So anything that is, shouldn't be there. So, yeah, tumours, metastases, etc. Same as what is the same with the shockwave. There's very little contraindications otherwise, really. I think you've just got to be more cautious with under 18. Again, is one of them in there. So we don't want to be necessarily looking at preteens. Around the growth plates, but otherwise you're not really restricted with the laser a massive amount. The shockwave contraindications are the same as what they've always been. Be aware with anticoagulants, kind of look at those as your rivaroxabans and your warfarins, etc. So be aware of anticoagulants or antiplatelet medication. Again, your metastases, etc. I have got a slide on contraindications, I think, somewhere, so I can add that in and we can circulate that. But there's not many really with the laser, which is great, which means that you can pretty much use this on any patient that walks into the door. There really isn't a great deal. I think the main one is over any metastases or bone, kind of any growths that we have concerns. Obviously, the concern there being is that we will stimulate something that shouldn't be stimulated. But otherwise, corticosteroid injections are also a contraindication from a shockwave perspective. We go 6 weeks for the upper limb, 8 weeks for the lower limb. So you've got your basics and your standard ones that we get with shockwave. That hasn't changed. With the laser, you've very little really that you need to be concerned about. I think that it's just that the trick comes with adapting the settings to suit the patient over the tattoos and the pigmentation. That's the key art to it. And then the rest of it is absolutely fine. There's very little that you need to be worried about with the laser. It's very safe, it's very effective. You just need to be considering, you know, it's the usual, don't go anywhere near cancers, and don't go over really any growths that you think are suspicious. But no, nothing massively, but I'll get the slide up for that now, just to 100% confirm that I'm not missing anything of massive significance. Let me, I have got that slide, I can get that up for you straight away. That one. Contraindications, recap. There you go. So we have, neoplasms, pregnancy, and pacemakers. That is pretty much it. So if there's any neoplasmic growths, we stay away from that. If there's pacemakers, we stay away from those. And if they're pregnant, we don't use laser on that as well. Again, you know, do I think that using laser on a pregnant lady with plantar fasciopathy is going to really affect the fetus? I highly doubt it. But it is predominantly a litigation perspective that if anything did go wrong with the fetus, the parents may look for a blame. So that's the main reason why there's pregnancies in there. But otherwise, there's very little that you need to be concerned about with the laser. So we've got 5 minutes or 10 minutes, and I'll walk you through the lower back. So again, we'll do the 3 minutes here. I'm going to just put my glasses on, and we will. Oh, I can't see now. There we go. There's Chris. Right. So, for example, start. So what I tend to do with the lower back is we want to angle in. It depends on what we're trying to treat here, but we want to angle in a little bit towards the facets. Now I tend to go just up and down a little bit. Again, you can be very specific around the location, the area that you want to be treating. So if you wanted to go into the SI joint, you can angle specifically into the SIJ. If you want to be going into the facets, you can angle specifically into the level and the facet level that you want to be angling at. Now for me, I just tend to run up and down a little bit along the erectors. And that seems to have a really nice effect on an analgesic response. Then you haven't got any low back pain, Chris, have you? Occasionally, nothing at the minute. Yeah. So Chris has had a little bit of low back pain as a result of, you're not working from home anymore, are you? Yeah, so Chris is still working from home. So as a result of that, then obviously he's been changing his desk setup a lot, and his sitting postures have changed. So there's those sort of things. So we just run through here for 3 minutes. I won't leave the 5 minutes with this one. We'll just go straight into the shockwave. But typically, again, from a GDT perspective, we would leave that 5 minutes. Right, just a final minute here. It's really good for the low back, though. I've used this quite a bit for low back pain, particularly in those real acute spasms. It works really well for this, just to reduce down some of the pain, and it allows us then to actually, like as a chiropractor, it allows us to do a little bit more with the patient. to try and get that little bit extra out of the manipulation, maybe allow them to relax down a little bit, get into less pain to get them into more positions. So it does work quite well from that perspective as a lovely adjunct with it in the low back pain. You can of course use it in isolation. There's no issues to why you can't use it in isolation. We got 10 seconds. There we go. So no, typically we would leave it for the 5 minutes. We haven't got time to leave it for the 5 minutes, unfortunately. But what I will then do is, because this isn't as pressing for Chris, we haven't got to worry about it too much in terms of what he needs from me today in terms of low back pain. The shoulder is the main issue for him, so we'll work on that. Sorry, switch past. There we go. Right. So again, what I tend to do with the low back is we pick a couple of trigger points basically along the erectors here. So I tend to pick 3 separate points as we go along, and then pop them down. Now I tend to keep these settings pretty consistent, so it tends to be, oh, I can take my glasses off now and I can finally see. So we tend to put these 2.8 bar up at 12 hertz, and that will be for 500 impulses per spot. So what I'll do, we'll pop 500 in here, just angling medially. We don't want to be going to the laterally at all. Obviously, with the penetration levels that we can achieve, Chris is slightly, he's got a lot of muscle bulk, but he's not a large patient. This means that you don't want to be going too into the posterior aspect of the abdominal wall. That's quite tight there, Chris, actually. Chris is a little bit tight on this left-hand side, actually. So, yeah, possibly. Just actually said it might be the way that he leans with his desk setup, maybe to one side. There we go, and then we have one more on this left side, and we'll do the same then on the right. Any seconds, and then we'd repeat on the other side, which we may as well do as we hear them. I would normally be around the other side, but I'm I'm learning left-handed. More. Dempsey, while this is going on, is there any questions there?
Yes, we have a couple of questions. Let me check. Is the GDT protocol suitable for patients suffering from coccydynia? And if so, what would be the most suitable device? Can you hear me, Daniel?
I didn't hear that. My internet connection. Yeah, my internet connection is just gone. But yeah, go on. What was that?
No, I was just saying the question was, is the GDT protocol suitable for patients suffering from coccydynia? If so, what would be the most suitable device, both or only laser or shockwave?
Difficult one, coccydynia, because of its location. I have used shockwave on coccydynia over kind of the sacrococcygenial ligament, and it's not the nicest treatment in the world to go through for the patient. It's certainly worth a go, I would say. I think from the perspective of what else can we do? And there's multiple causes to coccydynia, which is the issue. It's not as simple as saying, we have. That's done. Sorry, it's not as simple as saying, it comes under an umbrella term, but there could be inflammatory changes, there could be ligament sprains, there could be fractures. There's all of those different potential causes as a result of, that leads to coccydynia. From a perspective of, if you don't try, we never know. It's not one of those. It's not one of the ones that are in the list for what is appropriate and what isn't. But is it something that you may want to try and potentially try a little bit of laser on in isolation? Is it something that maybe you want to try in combination? Yes, you could. There's no reason why you can't. It's safe to do it, providing that there's no contraindications. I would just be aware that it's more of an experimental approach rather than a definitive answer of saying yes, you can do it. It's something, yes, you can do it. I don't know what results or outcomes you would get. I've used it on shockwave before. I didn't get a great deal of outcomes with that individual. Maybe in combination you may, but again, maybe it just wasn't the right type of coccydynia. We actually sent that individual for an MRI, and there was like a big ball of inflammatory kind of process that was going on the deep side of the coccyx. So, shockwave wasn't going to change that, and I highly doubt that the laser would have reached that for penetration. So, like I said, it depends on the reasons as to why you have that coccydynia in the first place. But is it safe to do, providing that there's no contraindications? Yes. Could you get outcomes? There's no reason why you wouldn't, or there's no reason why you couldn't get outcomes or good outcomes with it. So it's worth a go, particularly with these patients. They're in agony a lot of the time, and it is just constant pain for them. So I would try it and see where that takes you.
Okay, thank you, Dan.
Let's see.
Thank you.
I'm running over Chris's shoes. That's okay. Just out of interest, have a little bend and.
Wow.
So Chris is actually a little bit stiff earlier, I said, so that's made a big difference for him.
That's much better.
Yeah. That's it from me, I think. So if there's any questions, I'm happy to answer them. Thank you, Chris.
Yeah, we have just a couple of questions. A question from Ingrid: is that vibration reverted to the transverse process as well? Because that could have a terrible manipulative effect, almost like unilateral PA or transverse MODS.
It's possible. I think that what we say as a rule of thumb is that there's a centimetre per bar. Now I set the bars at 2.8, which means that it's only going to go approximately 2.8 centimetres. So from that perspective, we know that the majority of people have around about 3 centimeters of depth of multifidi. So it's unlikely to reach the facets and the TVPs at that level. If you start going up into 3 bars and above, then that's when you potentially will get those penetration levels. But yes, so that's why we choose those settings, so that it doesn't actually kind of reach deep into the joint. If you wanted to, when you were aiming for those joints, then you can add higher pressures and higher energies.
Okay. Thank you, Daniel.
No problem. Oh, I'm a bit high now, sorry.
Another question, a question from Sammy. Can laser therapy be used for partial rupture on the supraspinatus?
Yeah. I mean, partial ruptures or partial tears. Yeah, there's no reason why not. Absolutely no reason why not. Alongside some decent rehab, that'll come in quite nicely. The aim of that will be, during those acute phases of tearing, will be to reduce down the nociception and the pain responses and increase that, reduce the inflammatory response, to then build a window essentially for them to rehab pain-free. I think that the rehab is going to be very important with that as well. But it is 100% suitable to try and get that pain-free window to get a decent rehab program and treatment program in. Yeah, 100%. I think that in the acute phases, go laser and isolation. I think that you want to be a little bit careful with shockwave with them. If the tendon's compromised, then maybe too high of energy may actually damage that tendon. So I would definitely stay away from the Pyzaclast with partial tears. But yeah, 100%, you can 100% use laser on that, no problem at all. And then progress into your decent, a good load-in and rehab program, establishing your range of motion initially, and then going through into some gentle load. No issues why you can't do that at all.
Okay, perfect. Thank you, Dan. A question from Samantha. Can you use shockwave therapy to treat a distal radius exostosis? Would it help?
Oh, interesting.
Yeah, I don't think we have.
I wouldn't be. It may help from pain. It's not going to do anything in terms of actually changing the exostosis itself. So from a pain perspective, it potentially would help, as would laser. So it potentially would help from that perspective. I don't think that it's going to change things structurally. So if your thoughts were, am I going to break down and kind of damage that exostosis? Are we going to kind of break it down and disintegrate it? Probably not. If you're thinking, can I help with pain? 100% yes, more than likely you can. It's just going to be a little bit of a tender area to apply high energies in. So it could be done. It just depends on what you're thinking from goals perspective. If you want to really destruct that exostosis, I highly doubt that you will gain anything from that. If you are looking at it from a pain relief perspective, then yeah, it's feasible.
Okay, perfect. Thank you. We have 2 last questions. A question from Winston asking, could you please demonstrate how to use the standalone arm of the laser?
Oh, yes, I can. That's easy, actually.
Yeah, very easy.
So, let me bring this over, wheel my chair out of the way. I haven't got a big enough room, apparently. Okay, so the standalone arm, it's really nice and easy. This is obviously clipped into the side, and your standalone arm is just nice. And we clip that into there. And that now can just change your angles up and down as you want. It will come around. I'll have to go that way to go around. But you can come around, bring it down over to whichever side of the bed you want. So that would be ready there for the bench. And then you can change that angle just by tightening those. And it's really nice and easy. The difference being here, for example, if we go into indications, we're looking at knee for example, and you wanted to do a medial tibio-femoral or do a patellar tendinopathy, you'd put it on the automatic setting. It tells you where to place it, how to do it. You then press next and get ready, and that is it. And that is a 19-minute session. So you can be doing 19 minutes for whatever you wanted with that placed onto the patient's patellar tendon. And you can choose, obviously, your angles. You can strain that around. This is going around the back a little bit here. So in an ideal world, it would be coming around the front. There you go. So that changes it a little bit, makes it a little bit easier. And then that is you done. So you can put that wherever you want. So the standalone arm is really simple, really easy, really basic to use, and really quite nice to have, actually. And then it will pretty much just unclip out, if I can do it. There you go. And that then unclips. And you can then pop it back into there, and you can then fold that away as and how you want to. So it's a really nice and simple kind of idea, and it does allow you to multitask in the treatment room whilst you're doing it. So really good, really nice. I tend to do mine manually just because I like to stay with the patient. I have done it a few times with automatic, but if you are one of those practices that work on multiple patients at one time, then you can 100% do that. With this, it does, you're not limited then. From some people, what we have sort of seen is that people will come in, they'll do 10 minutes, 12 minutes of laser or whatever the protocol is that they choose, and then they'll allow them to leave whenever they've finished. So it's a separate room. They come in, they set themselves up. Maybe you teach them how to do that in the initial sentence. They pay as they leave, and you don't really have any interaction with them. So that is something that is feasible with these. So yeah, it's a really nice addition.
Thank you for the demonstration, Daniel. Last question from Michael, and this is a question of fees. What would you typically charge for a session combining both therapies?
That's a really interesting one. I haven't changed my fees. I've added the laser in as no additional charge. But I think you can definitely add something to that. For example, one of the business models that has been floating around has been, look, we'll see you 3 times a week, because when you're doing the laser in isolation, you will need to see them regularly. Some of the sessions are 10, 20 minutes. So you say, look, you come in for 20 minutes at a time. You do it yourself with the automatic arm, and that will be £20, for example. And that would mean that you get an increased revenue there of £60 a week. Which is maybe the equivalent to 2 sessions of chiropractic care or whatever it is, or 1 session of chiropractic care. But for an hour of their time, you're still paying, so the room is paying for itself really, and you can be doing other things with the arm. From a business model, it's very new for me. I think that we're looking at it from even trying to introduce it for an hour gap and things like that, and I haven't quite worked the way to do that and how to fit that into our business model. But typically, I don't think that, depending on where you are in the world, I don't think anything above £80 to £100 a session for combined isn't unreasonable. So it really does depend on where you are, what you're doing, and your environment that you're in. But there's no reason why you can't charge additional extra. It really is on your business plans and your locations that would depend that for me. But yeah, that's up to you, I think.
Okay, thank you, Daniel. And we have a quick last question from Rungi. Oh, sorry for the name. Rumpiada. What is the material of the laser's cable? Fiber optic or else?
That is not for me. I do not know. Yeah. I do not know.
I can answer this question by email if you want, Rumpiada. I will send you the answer and check with our engineers. No problem.
Yeah, well,
So,
I'm sorry, I wasn't involved with the manufacturing element of it.
so well, last question from Winston. Do you provide rent to own options? Yes, I think we do, but this is a question for our local
Sales team,
distributor.
yeah.
So I will as well answer this question by separate email. Okay, we are coming to the end of this webinar. So thank you, Daniel, for the demonstration and practical session with Chris. Thank you for arranging all that, the material and the patient. That was great. Thank you all for your participation, and please feel free to send any questions to me, us by email, and we'll answer them as soon as possible. We hope you enjoyed the session, and thank you again. Take care. The replay will be sent. The replay and the link to the replay will be sent by email as well, and probably tomorrow. And so you can watch it at your convenience if you could not attend the whole session. Thank you again, Dan, and we keep in touch for the next session next month. Thank you all.
Yes, thank you. Thanks, MC.
Thank you. Take care. Bye-bye.
Bye.
Bye-bye.